മെന്ന് ഓഡിയൻസ് ഇല്ല അല്ലേ?
ആ സാർ ഞാനൊന്ന് മെസ്സേജ് ഇട്ടു എല്ലാവർക്കും.
അല്ല, ഡെയിലി ഇന്നലെ ഉണ്ടായിരുന്നല്ലോ, അതുകൊണ്ട്.
ഇന്നലെ ഉണ്ട്. അതെ അതെ
ഇന്നലെ
അതെ
ഉണ്ട്.
സാർ. നമുക്കൊന്ന് വെയിറ്റ് ചെയ്യാം സാർ. നമുക്ക് എന്തായാലും കുറച്ചൊന്ന് വെയിറ്റ് ചെയ്യാം.
5 മിനിറ്റ് വെയിറ്റ്
കൂടിയിട്ട്
ചെയ്യാം, കുഴപ്പമില്ല.
വെയിറ്റ് ചെയ്യാം. ഗുഡ് ഈവനിങ് മാഡം, കൽപ്പന മാഡം. ഗുഡ് ഈവനിങ്
Good evening,
പ്രിയൻസി സാർ.
കൽപ്പന.
ഗുഡ് ഈവനിങ് സർ. അങ്ങനെ ന്യൂ ബോൺ ഒക്കെ പഠിച്ചുകൊണ്ടിരിക്കുകയാണ്.
ഗുഡ് ഈവനിങ് സാർ. ഭയങ്കര പ്രോംപ്റ്റ്.
അതാണ് സാർ കറക്റ്റ്, ബാലസാറും കറക്റ്റ് ആയിട്ട് വരുന്നുണ്ട്.
ഗുഡ് ഈവനിങ്. ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് കൽപ്പനാടോ. PMC സാറേ ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ്. ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് റിയ സാർ.
ഗുഡ് ഈവനിങ്. ഗുഡ് ഈവനിങ്.
ഗുഡ്
ഞാന്
ഈവനിങ്.
തൃശ്ശൂര് വന്നേ. ഇന്ന് ഇവരുടെ ഇൻസ്റ്റലേഷൻ. അപ്പൊ അങ്ങനെ
ഫെബ്രുവരി ആയി അല്ലേ? തൃശ്ശൂർ ആരാണ്?
തൃശ്ശൂർ ഇത്തവണ ഇട്ടൂബ് സാറും നമ്മുടെ സുനിൽ എന്ന് പറഞ്ഞിട്ട് അമലയില് ഒരു ഡോക്ടറുണ്ട് മാഡം. പുള്ളി നേരത്തെ
സുനിൽ മേനോൻ.
അമലയിൽ സുനിൽ.
ഏത് യൂണിറ്റ് ആലപ്പുഴയില്?
ശ്രീലത മാഡത്തിന്റെ കൂടെ.
ആണോ?
P1
അത് P1 അല്ലേ?
P1. സെക്കൻഡ് യൂണിറ്റ് ജയറാം സാറ്, തേർഡ് യൂണിറ്റ് ജോസ് സാറ്. ന്യൂബോൺ പൂർണിമ മാഡം. നമ്മള് നാളെ അവിടെ എൻഡോക്രൈൻ ക്ലിനിക്ക് തുടങ്ങിയാണ്. എൻഡോക്രൈൻ ക്ലിനിക്ക് ഇനാഗുറേഷനൊക്കെ വെച്ചിട്ടുണ്ട്. രേഷ്മ ഇല്ല മാഡം, രേഷ്മയ്ക്ക് ഏപ്രിലിൽ കഴിയും.
ഏപ്രിൽ 2 മാസം.
രേഷ്മയുടെ ഞാൻ തിരുവനന്തപുരത്ത് വരാനാണ് പറഞ്ഞിരിക്കുന്നത്. നമുക്കവിടെ വേക്കൻസി നിലവിലുണ്ട്, പക്ഷെ അറിഞ്ഞൂടാ.
അവള് വന്നാൽ നല്ലതാണ്.
നമുക്കൊരു ചെറിയൊരു ഫെലോഷിപ്പ് പ്രോഗ്രാമോ എന്തെങ്കിലുമൊക്കെ ആദ്യം തുടങ്ങാം. പിന്നെ പതുക്കെ ലോങ് ടേം നമുക്ക് പേഷ്യന്റ് ഉണ്ടല്ലോ, ഒരു സിസ്റ്റം ഉള്ളത് കൊണ്ട്.
അല്ല, എനിക്ക് തോന്നുന്നു പിന്നെ 2 പേര് ആയി കഴിഞ്ഞാലേ
2 പേരുണ്ടെങ്കിൽ ചെയ്യാം. അതെ, അങ്ങനെയാണ്
സ്റ്റാർട്ട് ചെയ്യാം. പീഡിയാട്രിക് എൻഡോക്രൈനോളജി ഇപ്പം എവിടെ വേറെ ഉണ്ട്?
ഇപ്പൊ മാഡം പീഡിയാട്രിക് എൻഡോക്രൈൻ തുടങ്ങിയിരിക്കുന്നത് നമ്മുടെ എയിംസിൽ തുടങ്ങി. ഡൽഹി എയിംസില്. പിന്നെ അതാണ് അവർക്ക് ഇൻസ്റ്റിറ്റ്യൂട്ടിലേ പറ്റത്തുള്ളൂ മാഡം. ഇൻസ്റ്റിറ്റ്യൂട്ടില് അവര് തീരുമാനിച്ച് അങ്ങ് തുടങ്ങും, ആരോടത്തും ചോദിക്കണ്ടല്ലോ.
അവർക്ക് കോൺസ്റ്റിറ്റ്യൂഷണൽ ഇതാണ്.
അതെ. അതുകൊണ്ടാണ് അവർക്കെല്ലാം
വേണ്ട, പല സ്ഥലത്തും ഒന്നും ഇല്ല. മറ്റെന്തുവാണ് അവിടെ ഗ്യാസ്ട്രോ കൊച്ചു കിടന്ന് കരഞ്ഞു പിടിക്കുന്ന കേൾക്കാം. എന്തോന്ന് അവളുടെ പേര്? ചേട്ടന്റെ ഒരു സ്റ്റുഡന്റ്.
സവിത. അല്ല, ഈ നമ്മുടെ രഘുവീർ സാറിന്റെ അടുത്ത് ബാംഗ്ലൂര് ഇഷ്ടം പോലെ കേസ് ഉണ്ടായിരുന്നു. അപ്പൊ സാർ അപ്ലൈ ചെയ്തിട്ട് ഇവര് വന്നിട്ട് കൊടുത്തില്ല. ഇഷ്ടം പോലെ കേസുണ്ട്.
വേറെ ആരെങ്കിലും ഉണ്ടോ
അവിടെ? വേറൊരാള് ഇത് ഫെലോഷിപ്പ് കഴിഞ്ഞ ഒരാളും കൂടെ ഉണ്ടായിരുന്നു, എന്നിട്ടും കൊടുത്തില്ല. അല്ല, അത് ഈ ഇത് NMC ആണ്, അന്ന് MCA ആണ്. പക്ഷെ അവരൊക്കെ അതിനകത്ത് ഭയങ്കര ഒരു നെഗറ്റീവ് ഇതാ. പീഡിയാട്രിക് സ്പെഷ്യാലിറ്റി തുടങ്ങുന്നതിന് ഭയങ്കരമായിട്ട് ബുദ്ധിമുട്ടിക്കും.
ന്യൂറോ തുടങ്ങിയത്
അതെ. സാർ അത്ര ഓടിയിട്ടാ അത് അങ്ങനെ. എനിക്കറിയാം സാറിനെ പറ്റി പറയുമായിരുന്നു.
താമസിച്ചിട്ടൊക്കെ ഉണ്ട് ഇവിടെ, പ്രശാന്ത് നഗറില്.
അതെ.
ജഗവതിയാണല്ലോ റിയാസിന്റെ സാർ അല്ലേ?
അതെ.
നമ്മള് പണ്ട് മുതലേ എൻഡോക്രൈൻ എന്ന് പറഞ്ഞ ഡോക്ടർ രഘുപതി. എത്ര നാൾ മുമ്പേ.
പിന്നെ PSN മേനോൻ സാർ നേരത്തെ. അപ്പൊ അവിടെ എൻഡോക്രൈനോളജി ഉണ്ടായിരുന്നെന്നാണ് എന്റെ വിചാരം. ഇത്ര നാൾ
എവിടെയാ സാറേ? ഇല്ല. അവിടെ ഈ പറഞ്ഞ പോലെ സാറൊക്കെ കൂടെ ഒരു എൻഡോക്രൈൻ ഡിവിഷൻ തുടങ്ങിയതേ ഉള്ളൂ. കോഴ്സ് ഇപ്പോഴാ തുടങ്ങാൻ പറ്റിയത്. ഇപ്പൊ വളരെ അടുത്താ തുടങ്ങി. സാറ് പിന്നെ അവിടെ നിന്ന് മസ്കറ്റിൽ പോയല്ലോ. PMC സാറിപ്പോ തിരിച്ചു വന്നിട്ടുണ്ട്. സാറിപ്പോ ഡൽഹിയിലുണ്ട്.
സാറാണ് ആദ്യമായിട്ട് ഈ ഗ്രോത്ത് ഹോർമോൺ സപ്ലിമെന്റേഷൻ ഒക്കെ നമ്മളെ പഠിപ്പിച്ചത്.
അതെ. നമുക്ക് തുടങ്ങാം ബെന്നോ, ലേറ്റ് ആക്കണ്ട.
ഇനി അങ്ങ് തുടങ്ങാം. 12
സർ ജസ്റ്റ് സ്പീക്കേഴ്സ് രണ്ടുപേരും കൂടെ ഉണ്ട്, അവരെ കൂടെ ഒന്ന്
ഓക്കെ 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 ഓക്കെ. ഈ നമ്മുടെ സൺഡേയിലെ പരിപാടി എത്ര മണിക്കാ തുടങ്ങുന്നത്?
സർ 8:30 രജിസ്ട്രേഷൻ, 9 o'clock ഷാർപ്പ് സ്റ്റാർട്ട്.
ശരി ശരി.
9 o'clock.
അതിന്റെ നമുക്ക് ഇനാഗുറേഷൻ അങ്ങനെ ഒരു സെഷൻ എപ്പോഴായിരിക്കും വയ്ക്കുന്നത്?
സർ നമുക്കൊരു 2 സ്റ്റേഷൻ കഴിഞ്ഞിട്ട് നമുക്ക് അങ്ങനെ ചെയ്യണോ സാർ? അത് സാർ പറയുന്ന പോലെ
നമുക്ക് നേരത്തെ അങ്ങ് തീർക്കാന്നേ, വെറുതെ ആളുകളെ
ഓക്കെ.
പഠിത്തത്തിന്റെ ഇടയിൽ ബ്രേക്ക് ഉണ്ടാക്കേണ്ട കാര്യമില്ല.
അങ്ങനെയാണെങ്കിൽ ഏറ്റവും എളുപ്പം തുടക്കത്തിലാണ്.
ഓക്കെ.
9 മണിക്ക് കാണാൻ വെക്കും.
2 വാക്ക് പറഞ്ഞ്
പറഞ്ഞിട്ട്. അതെ അതെ
ഓക്കെ മാം, തുടക്കം തന്നെ ചെയ്യാം.
അങ്ങനെയാണെങ്കിൽ മതിയല്ലോ.
മതി അതിന്റെ കാര്യം.
അങ്ങനെയാണെങ്കിൽ എനിക്കാണെങ്കിൽ അന്ന് വേറെ കല്യാണം, ഒരു നാഗർകോവിൽ കല്യാണം, പല പ്രശ്നമാണ്.
3 കല്യാണം ഉണ്ടെന്ന്.
അല്ല, പിന്നെ വൈകിട്ട് ബെന്നറ്റ് സാറിന്റെ അവിടെ പോണ്ടേ?
ബെനറ്റിന്റെ ഉണ്ട്. അപ്പൊ അതിനും പറ്റില്ല. ഞാൻ നാളെ ശനിയാഴ്ച ഞാൻ ആ കല്യാണം ബെനറ്റിന്റെ പോയിട്ട് ഞായർ മറ്റേടുത്ത് പോകാൻ പോണ്. ഞങ്ങളുടെ
നാഗോലിൽ പോയാ തിരിച്ചെത്താൻ പറ്റുമല്ലോ മാഡം? വൈകുന്നേരം അല്ലേ ബെന്നറ്റ് സാറിന്? വൈകുന്നേരം.
അതും വൈകുന്നേരം തലേദിവസം. അതിന്റെ തലേദിവസം. അല്ലെങ്കിൽ പിന്നെ മൺഡേ പോണം അവിടെ. അത് നടക്കൂല. അത് പിന്നെ ഒരു ദിവസം കൂടെ. സാറ്റർഡേ ഹാഫ് ലീവ് എടുത്ത് ബെനറ്റിന്റെ അവിടെ പോയിട്ട് തന്റെ ഹസ്ബൻഡിന് വേറെ ഒരു സ്റ്റുഡന്റിന്റെ കല്യാണം, അതും നാഗർകോവിലില്.
രണ്ടുപേർ കൂടെ പോവാം.
Riya sir, we'll start the session.
Yes, please.
A very good evening to one and all. As we all know that today is the third session and the last session of our online essential newborn care course, and we have very interesting topics for today. So before we start off with the topic, I would like to call upon Riya sir to speak a few words. And
respected President of IAP Trivandrum, Kalpana Madam, our beloved teacher, PMC sir, Dr. Benno, Dr. Bala, and all my friends here. So this is the third and final session of the online part of our newborn, essential newborn building. Hello, yes, can you hear me? Okay. So I was also able to attend the most parts of the last 2 sessions. Today I won't be able to attend, but so I found all the sessions very useful, simple and clear. The messages were all very clear. I once again thank the faculty team and the mentor PMC sir for making this so attractive and so useful. So the ice of the cake is actually coming on because we are going to have the actual hands-on session this Sunday, and all of us are awaiting that. Best wishes and happy learning. Thank you.
Thank you very much, Riya sir. In spite of sir's busy schedule, there is installation ceremony of IAP Trishur going on. So sir would be busy in that. Thank you, sir, for joining. And next, I would like to call upon our IAP Trivandrum President, Kalpana Madam, to speak a few words. Over to Kalpana Madam.
And dear Riya's IAP President, Kerala, Dr. PMC sir, my teacher and the mentor of this program, and Dr. Benno and Dr. Bala, and all the attendees and the faculty here. It is definitely a very nice program and very streamlined program, as I was telling before. And I'd like to hear from you regarding the final online session today, and then the offline workshop on Sunday. Over to Benno.
Thank you very much, madam. Now, I would like to call upon my very own teacher, my guru and my mentor, PMC sir, to start off with the first session. May I now invite our beloved PMC sir to talk on the topic thermoregulation in newborn. On to PMC sir.
Okay, thank you, Benno. Is it visible?
Yes, sir.
Yes, sir. Yes, sir.
Yes.
And you can hear me also. Okay. So we will go directly to the topic, thermoregulation in the newborn. Today we have 4 topics. We have to be strict on time. I'll be speaking only on the 10 pearls of wisdom so that we'll just remember. And if you look at hypothermia, preterm and low birth weight babies are predisposed to hypothermia. And it can also be a feature of underlying pathologies like acidosis, hypoglycemia, sepsis, and intracranial hemorrhage. So it causes a lot of morbidity and mortality. That is why we included this also in this topic. This 4 quadruplets I got from Varghese about 30 years back. And one thing you notice, none of the babies were clothed. That used to be very common those days. But we should understand at 23 degrees centigrade, a neonate suffers the same heat loss as a naked adult on the North Pole. So it is as poignant as that. So you have to be very careful in the babies. They can become hypothermic very fast and become very sick. And so the first carry home message, the pearl number 1 of wisdom is, no baby should be left unclothed or not swaddled up. Every baby's birthright is that they should be kept warm and should help them to survive. So the second pearl is strong recommendation by WHO. Unstable newborns less than 2,000 grams be cared in a thermoneutral environment. So what is the thermoneutral environment? It's a narrow range of environmental temperature at which the baby has a minimum basal metabolic rate, minimum oxygen consumption, and maintains the normal temperature. So you see the normal axillary temperature is between 36.5 to 37.5 degrees centigrade. And cold stress is somewhere, if anything goes below 36.5 to 36, we call it as cold stress. It's a cause for concern. So 2 questions. Then 36 to 32 is moderate hypothermia and by danger, and we have to warm the baby. And if it is severe hypothermia, less than 32, it is very grave situation. So how can a baby lose heat? 3 mechanisms are there. One is convective heat loss. A draught of air, currents of air can cause that. Evaporative heat loss in a wet baby. We can have conductive heat loss on the cold bed surface, and also we can have radiation to the outside. So the baby is warm, but the outside surface is very cold. The baby, from the heat, can be radiated from the baby to the outer surface. So signs and symptoms of hypothermia is actually variable, can vary from acrocyanosis and mottling to hypoglycemia, bradycardia, decreased activity, decreased weight gain, lethargy, and hypotonia, weak cry, etc. So suspect cold stress. Whenever you touch a baby, the feet feels very cold to touch, then that is the early sign of cold stress. You have to be careful, because if you're not careful, can end up in neonatal cold injury, causing bradycardia, metabolic acidosis, and even death. Hypothermia dangers can be one is hypoxemia, hypoglycemia, metabolic acidosis. Then you can have noradrenaline release, peripheral vasoconstriction, pulmonary hypertension, decreased weight gain, adverse neurodevelopmental outcome in the form of all the neurodevelopmental delays and NEC, ROP, apnea, septicemia, sclerema, DIC, all these are possible. So it's a very dangerous condition, and you can easily miss hypothermia. So how do you prevent heat loss in the delivery room? First, delivery room temperature should be kept between 26 to 28 degrees centigrade. All the fans should be put off, draughts of air prevented, and put the radiant warmer switched on at least 10 minutes before the delivery. And we should have pre-warmed blankets. We remember the olden days when he had only one sheet of cloth and 3-4 babies will be wrapped up in that, and there is no extra blanket to keep the baby warm. So that is a very important situation. You have to be careful in the delivery room. And once the baby is born, if it's a term baby, and the baby is crying and active, put the baby on mother's abdomen. Cover the baby, first of all, receive the baby in a warm blanket, then put the baby on mother's abdomen or on the chest if it is a cesarean section, for skin-to-skin contact in the prone position. And while doing that, you can do the cleaning and drying of the baby, and remove the wet sheet and wrap in another warm and dry sheet covering the head of the newborn. So most of the things are still not being done 100% in many of the peripheral hospitals because of the technical problems. And the other thing is we have to start breastfeeding as soon as possible. Even if you keep the baby prone on the mother's abdomen or chest, baby can crawl towards the so-called breast crawl and all that. So breastfeeding is quite possible immediately after that. So you can prevent heat loss at the time of birth by drying the baby, wrapping the baby, skin-to-skin contact, and breastfeeding. Then what happens if it's a preterm baby or maybe admitted to an ICU? The goal is the admission temperature should be between 36.5 to 37.5 degrees centigrade. So that is the pearl number 3. So temperature measurement is very important once the baby is being admitted. And other thing is the vernix. We must have seen the vernix on newborn babies. In our times, that is so many years back, where the attendant will take the baby out to the bucket and clean the baby nice with soap and water and give the baby back to you, and they get 50 rupees. But vernix is very important for the baby. It has got a barrier function against transepidermal water loss, mechanical protection during birth, and also thermal insulation. So heat loss will be prevented, especially the vernix should not be removed. So the main pearl number 4 is do not wipe off the vernix completely soon after birth. Do not. Then how do you give bath to the baby, newborn baby? Because many people have the doubt about it, when to give and all that. Should be a warm room. You should bathe the baby only after 12 to 24 hours after birth. Warm room, warm water, quickly give a bath and dry quickly and thoroughly, dress warmly and wrap. So the pearl number 5 is delay bath. It is recommended that for 12 to 24 hours you delay the bath, and the baby should be starting with the trunk and concluding with the head with this greater evaporative surface area, thus minimizing heat loss. So why these preterm babies are quite vulnerable to hypothermia? One is the low birth weight and preterm babies, higher ratio skin surface area to the weight, relatively large head, decreased subcutaneous fat, decreased brown fat, decreased glycogen stores, and the low levels of thermogenin, lower surge of thyrotropin, highly permeable skin with increased transepidermal water loss and increased evaporative heat loss. So these are the main problems with the preterm low birth weight. It's useful for the exam point of view. And suppose you have a preterm baby being born, 800 grams, and weight is 800 grams, and baby is less than 32 weeks. Then definitely it's IUGR also. Then the baby should be received in the delivery room, especially with the temperature around 26 to 28 degrees centigrade. And the baby should be received in a polyethylene bag without tray. These things have also come later when we are there, not there initially. So once you receive the baby in polyethylene bag without drying, the advantage it is retain the humidity. So transepidermal water loss will be less and it will prevent hypothermia. So any baby less than 32 weeks and less than 2 kg, polyethylene bag without drying, and these are so-called turkey bag up to the neck. And another important thing is the head should be covered. The head forms a large surface area. So cover with a warm cloth or cap. So the pearl number 6 is plastic wrap to prevent hypothermia in preterms less than 32 weeks, less than 1,500 grams. So nursery temperature should be 26 to 28, and once the baby is in the nursery, can be on the radiant warmer, incubator, polyethylene skin wrap with cam, thermal mattress or embrace, especially for transporting to small distances, warm humidified gases, increased room temperature, swaddling, and IKMCs, immediate KMC for the delivery room itself. So the question people ask is radiant warmer or incubator, which is better? Actually, both are good, but radiant warmer's advantage is cost effective, easy to clean, and also easy access is possible for doing procedures, examination, etc. Whereas incubators, on the other hand, are expensive, and also bacterial colonization can happen. That especially since we are using water in these incubators for humidification. But at the same time, the weight gain is good, ideal for very preterm and extreme low birth weight babies. And you can do procedures inside the incubator without the baby losing heat. Even in the radiant warmers, we can use a clean wrap or a heat shield to keep the micro environment and keep the baby warm. So another useful thing with the radiant warmer is that if there is a persistent heater output, as you see here, Then, in spite of the baby being under the radiant warmer, think of underlying sepsis, which is causing the baby to want producing heat. The baby is not stable, not able to maintain the heat production. So that is another clue to infection. Then whenever weighing the baby, use a sterile cloth towel or a paper towel while weighing to prevent heat loss. Then temperature measurement can be done with thermometers. Low reading thermometer is no longer recommended now. We have the rectal thermometer, especially for therapeutic hypothermia, but it also has risks like perforation, hemorrhage, cross infection, etc. Digital thermometers that were useful. And we have the thermistor probes in the radiant warmer incubator thermistors. This is attached to skin over the right upper abdominal quadrant, right hypochondrium, or on the flanks, in the prone, and on thighs rarely, especially in the abdominal area, we have the other lines. Then you may have to try on the thighs. So this will detect the skin temperature and display on the panel. Continuous record of temperature in sick neonates as possible. So another pearl is temperature assessment, very easy for the parents to be taught. Baby's abdomen, feet, and hands warm means thermal comfort, whereas abdomen is warm, peripheries are cold means cold stress, and abdomen and peripheries both are cold, think of real hypothermia. So that is easily detectable in the ward, in the crowded ward also this is possible. The lying in ward, you have to practice rooming in co-bedding, which we are doing nowadays. Baby well covered, close to mother, should be away from the walls because again radiant heat loss can happen. Oil application, skin in some states, liquid paraffin, plastic bubble sheet, aluminum foil, cap, woolen mitten, socks, etc. Delay bath till the baby is above 2 kg. So this is not in Kashmir or anywhere. It's keeping the baby warm in the outbound nursery house only. You have a cap, mittens, clothes, warm blankets, socks, etc. Surgery also, you have to be careful. The baby should be transported warm. Fluid and anesthetic agent should also be warm. And if heated mattress is available, it is better. Then transport incubator is ideal. Then best will be the mother. She will be the ideal biological transport incubator, covering the baby with woolen socks, caps, mittens, wrapped in cotton, thermocol balls, kangaroo care, skin to skin contact. So this is the transport incubator. And the other thing is exothermic mattress, embrace nest. That is also good for short transport. For example, for taking for X-ray, for MRI, or for transfer from delivery room to nursery is a phase changing material. So it can maintain the temperature for about 4 hours. Home care, of course, effective clothing, mother and baby together, hot away from the wall, and mother can assess the baby's temperature using the hand touch technique. So how can I teach a mother to keep the baby warm at home? Warm room, baby warmly wrapped up, kangaroo mother care, and breastfeeding. What is KMC? That's also important for the exam point of view also. Pearl number 9 is baby is less than 2 kg or 1.8 kg and not have any serious illness should be given KMC, Kangaroo Mother Care. So introduced in 1983 by Ray and Martinez in Colombia, especially when we had that, they had the shortage of staff and they gave the babies to the parents to look after, and the results were good. That is how the KMC came into use in Colombia first. So it facilitates breastfeeding, assists in maintaining the temperature of the infant, improves the mother-infant bonding, promotes physical growth and extrauterine adaptation. At the same time, hospital stay is reduced, so expenditure is also less. So the three components of newborn care in KMC are kangaroo position, kangaroo nutrition, and kangaroo support. So this is the kangaroo position, skin to skin contact between the baby's front and the mother's chest, and should minimum of 1 hour she should be doing that, and as long as even up to 24 hours or more. The kangaroo nutrition is exclusive breastfeeding. It's easy in this position, and KMC can be given by dads and grandparents also. Now the warm chain is a term used to describe a set of interlinked procedures which will minimize the likelihood of hypothermia. This is a WHO suggestion. The warm delivery room, immediate drying, skin-to-skin contact, etc. And finally, training and awareness to the staff is also important. So one word about hypothermia. because the core body temperature above 37.5 degrees centigrade is the commonest, is the definition of hypothermia. And the commonest situation where the doctor, especially peripheral hospitals, I see dehydration fever, how to differentiate from infection. Because dehydration fever is caused by raised environmental temperature, immaturity of the heat regulating center of the newborn, and inefficiency of sweating mechanism of the newborn. So this is quite often or occasionally we see in the periphery hospitals that babies brought at the temperature and you start antibiotics unnecessarily. So the point number 10 is here hot environment versus sepsis. Can easily differentiate. If you have the environmental temperature high, then the trunk and extremities of the baby will be of the same temperature or even more, and the baby will appear vasodilated. Whereas in sepsis, extremities are cooler than the trunk because of the peripheral vasoconstriction. So by touching the baby itself, you can make out whether it is really environmental temperature or real infection. And abdomen to toe temperature gap also will be more, especially if infection because of vasoconstriction of the periphery. Whereas environmental temperature, the abdomen to toe temperature may be same or even reversed. And management is not giving paracetamol, but cooling the environment, providing extra fluids, and removing excess layers of clothing. So to conclude, I think I'm keeping on time. Temperature assessment is a quality initiative as well as a quality outcome tool. Delivery room temperature should be 26 to 28 degrees centigrade. And whenever the baby is admitted, the admission temperature is very important. It's the predictor of outcome and quality indicator. So at any cost, avoid hypothermia, which can easily happen. Most of the babies transported from outside come hypothermic. And hypothermia should be prevented at any cost. And also we should have in-service teaching sessions, monitor practices, etc. So thank you for the patient listening. I think we can have the question answer in the end because there are 4 speakers. And covering the baby's head is very important, which also most often we forget. Okay, so thank you very much. Thank you, Benno.
Thank you, sir. Wonderful presentation. Sir, can I just take 2 minutes, sir? Just 2 minutes.
Okay.
Just 2 minutes. Sorry for that. Peter, sir, we'll stop the screen sharing, sir. I'll start the. Thank you very much, sir. We'll go on to the next session. Okay, I hope my slide is visible.
Make a slideshow. Okay.
Okay, sir.
Okay.
Thank you, sir. So now going on to the next topic. It is a neonatal hypoglycemia. As we all know that there is no universal definition for hypoglycemia. The normal range of blood glucose is variable. It depends upon factors like birth weight, gestational age, body stores, feeding status, availability of alternative energy sources such as ketones, lactate, and free fatty acids, as well as presence or absence of conditions that affect energy demand such as sepsis and birth asphyxia. Operation threshold has been defined by consensus. It is defined as a plasma or whole blood glucose concentration at which clinicians should consider intervention. So the important definition I can say is a whole blood glucose level of less than 40 milligrams per deciliter or plasma glucose less than 45 milligrams per DL has been taken as the operation threshold for intervention, and WHO defines hypoglycemia as a blood glucose level of less than 45 milligrams per deciliter. So there is yet another definition by the Pediatric Endocrine Society, which was released in 2015, specify that blood glucose level after 48 hours of life in newborn should be comparable to adult levels, that is 70 to 100 milligrams per deciliter, and at-risk infants should be evaluated for hypoglycemia with higher threshold, that is less than 60. So basically, less than, you can say if it is less than 45, you can label it as neonatal hypoglycemia. So there are n number of causes or indications for routine blood glucose screening. So in that, for a practical point of view, I would take only few points such as birth weight. So these are the babies whom we screen for blood glucose. So birth weight, that's less than 2.6 kg, gestational age, that is less than 37 weeks, SGA babies, infant of diabetic mothers, large for gestational age babies, that is more than 3.6 kg, any sick neonate, those with perinatal asphyxia, polycythemia, sepsis, shock, etc. during the acute phase of illness, and neonates, those who are on total parenteral nutrition. So schedule for blood glucose monitoring. We have to understand that each unit has their different timings or different ways of monitoring their sugars. So now, as we can see, at-risk neonates, when do you monitor? That is at 2 hours, 6 hours, 12 hours, 24, 48, and 72 hours of life. And sick neonates, that is sepsis, asphyxia, polycythemia, shock during acute phase of illness, you monitor every 6 to 8 hours. And units of TPN, every 6 to 8 hours in the first 72 hours, and after 72 hours, once a day. So each unit, what you can do is you can monitor each unit, as we say, that can be monitored. Initially, there is hypoglycemia, you monitor after half an hour to 1 hour, and after that, it will be either too early or third hour. And you can gradually taper over a period of time. So infants in whom screening is not required. So screening for hypoglycemia is not recommended in healthy breastfed term AGA babies. However, in term babies with poor feeding, poor stress, or born to mothers with inadequate lactation, definitely you'll have to consider for a hypoglycemic screening. So most common thing, like how do we screen for blood glucose in bedside? Though widely used glucose estimation by this method is unreliable, especially at levels in which the therapeutic interventions are required. Blood glucose level less than 40 to 50 milligrams. They are useful for screening purpose, but low values must be confirmed by definitely by lab testing. And it is crucial to consider the variations between capillary and venous, blood and plasma, and immediate and stored samples. So what are the minor changes which we see is whole blood glucose sugar value is about 15% less than that of plasma value, and blood glucose level, as we know, can fall by 14 to 18 milligrams per DL every hour in which the sample has been kept, and as we delay it, keeps on falling. So arterial samples, as we know, are slightly higher values than venous or capillary samples. The newer generation glucose reagent strips generate a current, that is when glucose reacts with enzymes such as glucose oxidase or glucose dehydrogenase, the amount of current is proportional to the amount of glucose in plasma. Second generation glucose readers are more accurate than the previous versions, but still unreliable in infants with low blood glucose level. So the gold standard will be always lab, that is blood glucose. This is the gold standard for measuring blood glucose. Glucose can be measured by either the glucose oxidase calorimetric method or glucose electrodes used in blood gas machines. Blood samples should be analyzed quickly to avoid erroneous low glucose values. And special mention, we have to transport in tubes which contains fluoride that contains glycolytic inhibitors, that is fluoride. So to make you understand a little more better, I think we'll go on with a few case scenarios. So coming on to the first scenario, this is a low birth weight baby, 37 weeks, 2.1 kg male baby, shifted to NICU because of the low weight. So does this baby need sugar monitoring, and how frequently will you monitor? So the initial value was 25. What is your action? Obviously, you'll have to give feeds, that is breastfeeding, and formula feeds. You have to note that subsequent values, that is subsequent values of 25 to 30 values, 2-3 values if you see, obviously you don't have to wait. When you check the next sugars, when will you check, and the subsequent sugars. So it has to be checked half an hour to 1 hour, 2 hourly for 2 times, 4 hourly for 2 times, and then every 6 hours. If sugars is safely more than 50 milligrams per DL. But what happens if the next value is 28 milligrams per DL? What will you do? So obviously you'll have to put an IV cannula, start off with IV fluids, send a CBC CRP stat, considering it to be a sepsis. So dextrose you'll have to give. So most important thing is dextrose, that is 2 ml per kg of 10% dextrose has to be given, and start your fluid at a GR of 4 to 6 milligrams per kg per minute. You'll have to send a blood culture and you can start your first line antibiotics. So when will you repeat the next sugar? Half to 1 hour, then 2 hourly 2 times, then 4 hourly 2 times, and then every 6 hourly until the sugar is, when the sugar is more than 50 milligrams per DL. So next sugar again is 35. What will you do? So already you have kept the GR at 4 to 6. Again, you'll have to increase your GR to reach up to 8 milligrams per kg per minute. And the next value when you check is 62. What will you do? Will you maintain it for next 24 hours? Yes. After 24 hours, you reduce the GR to 6. That is, you wait for at least 24 hours and then gradually you start to reduce. Start 2 hourly feeds through feeding tube. If sepsis screen is negative, you can consider stopping antibiotics and then 2 hourly sugars. Next scenario is 37-weeker, 3.25 kg male baby, shifted to NICU because of inadequate weight gain. Day 10, child weight was 2.75 kg. So there is almost a 15% weight loss. This scenario would be a normal baby weight with suspected sepsis. So does the baby need sugar monitoring? How frequently will you monitor? So the blood sugar at 1 hour is 25. What will you do? You will have to give feeds, mother's feed, and as well as formula feeds. When will you just check the next sugar and what are the subsequent sugars? So as we know, it is half an hour to 1 hour, 2 hourly for the first 2 times, 4th hourly for the next 2 times, and then every 6 hourly if sugar is more than 50 milligrams per deciliter. So the next sugar value is 28 milligrams per DL. What will you do next? Secure an IV cannula, IV fluids, and considering it to be sepsis, you send a CBC CRP and also blood culture. Dextrose, very important. You give 2 ml per kg of 10% dextrose. Start the GR start a GR of 4 to 6 milligrams per kg per minute. And first line antibiotics has been started. Next sugar, when you repeat, that is half to 1 hour, 2 hourly, 4 hourly, 6 hourly. And next the repeat sugar is about after 1 hour is 35. So increase the GR to 2 milligrams per kg per minute when you reach up to 8 milligrams per kg per minute. Next sugar is 62. So you maintain. So it's safe. So you maintain up to 24 hours. After 24 hours, gradually you can decrease your to 6 and then start a subsequent feeding tubes. Sepsis screen positive, E. coli, continue. Sepsis, you can continue antibiotics. Then 6 hourly sugars you can see. So symptoms of hypoglycemia includes neurogenic, autonomic, and uroglycopenia. So what are the symptoms? Symptoms of hypoglycemia are variable. It includes stupor, jitteriness, tremor, apathy, episodes of cyanosis, convulsions, intermittent apneic spells, tachypnea, weak and high-pitched cry, lethargy, and difficulty in feeding. So asymptomatic hypoglycemia said to be present when blood glucose less than 40. Symptomatic should be diagnosed with hypoglycemia coexist with the clinical symptoms as we discussed earlier. So asymptomatic hypoglycemia, what can you give? So direct breastfeeding is the best option for the trial of oral feeding. If the infant cannot suck, express breast milk can be given. And if breast milk is not available, definitely you'll have to go for formula feeds. And recently, buccal dextrose gel has been used to treat asymptomatic hypoglycemia. Commercially available gels are present, which is applied to the dry buccal mucosa, and infant is encouraged to feed. Blood glucose rechecked after 30 minutes after gel. It has been found to reduce the number of episodes of hypoglycemia, recurrence rate, and the need for admission to NICU and improve exclusive breastfeeding rates at discharge. So symptomatic hypoglycemia, as I repeated in the case scenarios, you'll have to give 2 ml per kg of 10% dextrose, that is 200 mg per kg, should be given, including those babies coming with seizures. So this is the tabular column. It is divided into symptomatic, asymptomatic. Asymptomatic, you give trial of oral feeds, monitor the blood sugar after 1 hour, less than 40 and more than 40, less than 40, frequent feeds, monitor sugar 6 hourly, stop after 48 hours. So symptomatic, bolus of 10 ml per kg, 10% dextrose, infusion rate 6 milligrams per kg per minute, and gradually you monitor and see. If it is less than 50, you increase your GR. More than 50, you keep it stable for 24 hours, and then gradually try to taper it. So this is the algorithm for treating asymptomatic and your symptomatic hypoglycemia. So next, practical, So a practical tip is, if there is persistent hypoglycemia, check the IV line patency. See, even if you are actually going on your and then beyond, still your sugars are not being maintained, then definitely you'll have to check for the intravenous line for patency. Also check the IV fluid preparation and your infusion rate. So one more thing is, avoid using more than 12.5% dextrose infusion through a peripheral vein due to the risk of thrombophlebitis. You'll have to insert a UVC. I think we'll have this session of practical, that is all these procedures, everything we'll be discussing in the workshop session. And once a rate of 4 milligrams per kg per minute of glucose infusion adequate low intake is achieved, blood glucose level consistently above 50 milligrams, infusion can be stopped. So this is a practical aspect. So next, coming on to what is resistant or recurrent hypoglycemia. So the definition says this condition should be considered when the infant fails to maintain the normal blood glucose level despite a GR of 12 milligrams per kg per minute, or when stabilization is not achieved by 7 days of therapy. So what are the critical samples? So this is very important. Diagnosis of hyperinsulinism is based on critical sample. Definitely when there is hypoglycemia, you have to send glucose, insulin, cortisol. You started off with fluid to decrease your GR requirement. So first thing is hydrocort, that is 10 mg per kg per day BD. This can be given orally, per orally and IV. What is the mode of action? Reduces peripheral glucose utilization and increases gluconeogenesis and increases glucagon effect. Next drug would be diazoxide. So my personal experiences with hydrocort and diazoxide. So diazoxide, your dose is 5 to 15 mg per kg per day TID. Can give per orally. It is a potassium channel agonist. Next is octreotide, that is 5 to 35 microgram per kg per day. One second, I think I'll mute everyone. Sorry. Okay, fine. Sorry. Yeah. So next is octreotide, that is 5 to 35 micrograms per kg per day TID. Sorry for that. I'll just mute everyone. Yeah. Okay. Yeah. So next is glucagon, that is 0.2 microgram per kg. This includes this subcutaneous or IM. This can be action is glycogenolysis and increased gluconeogenesis. Next, case scenario 3, low birth weight, 37 weeks, 4.1 kg, female child. So it's a large baby. Does the baby need sugar monitoring? How frequently? Blood sugar at 1 hour is 25. You give feeds and mother's milk. Will you check the sugar next? Same thing, half an hour to 1 hour, 2 hourly for 2 times, 4 hourly for 2 times, and 6 hourly if sugars are more than 50. Next value is 28. You will have to start off with your IV fluids, 2 ml per kg of 10% dextrose, GR of 4 to 6 milligrams, blood culture, antibiotics. When will you repeat the next sugar? Half to 1 hour, 2 hourly 2 times, 4 hourly 2 times, and 6 hourly. Next case scenario 4, it's a normal weight baby with hypoglycemia. This is the last case, and 2.8 kg baby with reduced weight, that is reduced to 2.4 kg, came with seizures. So seizures, as we know, when the weight reduces to less than 2.5 kg or below, you have to be alert, and this child can be present with hypoglycemia and seizures. Therefore, to prevent it, we have to teach the mother to give express mother's milk after each direct feed, even at night, and correct any breastfeeding problems, especially when there is poor attachment. Here also, you secure an IV cannula, give 2 ml per kg of 10% dextrose, then think of starting off with anti-epileptic drugs. Repeat sugar after 1 hour, 35. What will you do? Increase GR to 2 milligrams per kg per minute to reach a 8 milligram per kg per minute. Next sugar 34. Increase GR in 2 steps until you reach a GR maximum of 2 milligrams per kg per minute. What is the next step? Obviously, you have to send the critical sample, insulin, cortisol, ACTH, and urine for reducing substance. After 24 hours, reduce your GR by 2 milligrams per kg per minute. Start hourly feeds through feeding tube. If sepsis screen is negative, then stop antibiotics, then 2 hourly sugars. Criteria for diagnosis of hyperinsulinism: insulin. Even if low amount of insulin is detectable, it is hyperinsulinism. Your fatty acids will be low ketones, and inappropriate glycemic response when giving intravenous glucagon at the time of hypoglycemia. So important cause of Western hypoglycemia, there are a number of causes. There is hyperinsulinic hypoglycemia and normoinsulinic hypoglycemia, potassium channel defects, glutamate dehydrogenase. In case of normoglycemic, glycogen storage, organic acidureas, galactosemias. Investigations to be done in resistant hypoglycemia, serum insulin levels, cortisol levels, hormone levels, growth hormone levels, serum lactate, free fatty acids, TMS, that galactose 1-phosphatidyl transferase, urine ketone, urine reducing substance. So most important thing, what we have to know is calculation of GR. There are 2-3 calculations. One for practical purpose, or which is easy for everyone to calculate, would be, that is, infusion rate would be percentage of that your ml per kg per day into percentage of dextrose by 140. For example, if you're taking 60 ml per kg per day, that is on your requirement of day 1, is 60 ml per kg per day into 10% dextrose would be 60 into 100 would be 600 divided by 144. So your GR will come approximately 4.1. That is 4. So this is your, choose any one formula and stick on to it and try to increase your GR accordingly. So this is the tableau calling for achieving your desired infusion rate, your GR. That is, you mixed D10, D25, and then you get your desired amount of fluid to increase your GR. And add 20 ml of kg of normal saline to provide 3 milliequivalents per kg of sodium. So what is your follow-up and outcome? Particular attention should be paid to the neurodevelopmental outcome, overall IQ, reading ability, arithmetic proficiency, and motor performance. Infants must be assessed at 1 month corrected age for vision. At 3, 6, 9, 12, and 18 months of corrected age, they need to be followed up for neurodevelopment, vision, and hearing. Vision can be assessed with teller equity cards, while hearing is assessed by brainstem auditory responses. So hypoglycemia and neurodevelopmental outcome, what is the evidence? Recently published children with hypoglycemia and the later, that is child study, prospectively evaluated the long-term effect of neonatal hypoglycemia in 477 at-risk late preterm and term neonates, reported that hypoglycemia was not associated with increased risk of combined neurosensory impairment at 4.5 years, but was associated with a dose-dependent increased risk of poor executive function and visual motor function, severe, recurrent, and undetected episodes of hypoglycemia, and there is increased risk. Thank you all. So as we discussed, we think we'll take the questions in the end. Next, I would like to call upon the next speaker for day is none other than Hazeena Madam. Madam is consultant neonatologist at NIMS Hospital. And the topic Madam is going to present is neonatal hyperbilirubinemia, current concepts in management. Over to Hazeena Madam.
Hello.
Yes, Madam.
PMC sir, Kalpana Madam, Riyas, Benno, Bala sir, for giving me the opportunity to participate in this essential newborn care workshop, online and offline. I'll share the screen. Is it visible? Is it?
Yeah.
Vanilla, Madam, it is just coming. Okay, Madam. Full screen cheyda, screen sharing. Sorry, slideshow. താഴോട്ട് വന്ന മാഡം മറ്റേ ബുക്ക് കാണുന്ന ആ ഒരു സിമ്പിളിന്റെ അടുത്ത് താഴെ മാഡം ഏറ്റവും താഴെ മാഡം നോട്ട്സ് കമന്റ്സ് എന്നൊക്കെ പറഞ്ഞിട്ടില്ലേ നോട്ട്സ് കമന്റ്സ് താഴെ നോട്ട്സ് കമന്റ്സ് ഏറ്റവും താഴെ മാഡത്തിന്റെ കേഴ്സർ മെയിലിലാണ് കേഴ്സർ താഴോട്ട് കൊണ്ടുവരിക നോട്ട്സ് ആൻഡ് കമന്റ്സ് കാണുന്നുണ്ടല്ലോ അതിന്റെ തൊട്ടടുത്ത് ഒരു സിമ്പിൾ ഒരു ബുക്കിന്റെ സിമ്പിൾ കാണുന്നുണ്ട് അതിന്റെ കറക്റ്റ് അതെ
ഓക്കെ
ഓക്കെ മാഡം
So my topic is neonatal hyperbilirubinemia, current concepts and practices. I will try to focus just on the AAP 2022 guideline, because this is a huge topic and all points cannot be covered. I'll just try to concentrate on the 2022 guideline. So what is neonatal jaundice? It is one of the most commonest conditions that we encounter on a daily basis. All of us, neonatologists, pediatrician, at least even some of our relatives or friends will call us and ask, this baby is having this much value. Is it right to start phototherapy? The doctor is telling this. So it is better to have good information about neonatal jaundice. So it's the commonest condition, that is one of the commonest condition that occurs in almost 60% of term babies and 80% of preterm babies. It is most commonly physiological and maximum values seldom exceed 15 milligram per deciliter. Appears usually after 24 hours of life. Usually decreases within first 1 week, and it is almost always undetectable after 14 days. So just rushing through the physiology, because this is always helpful in counseling the patients. The RBCs, when they break down, heme and globin is formed, and heme is acted upon by heme oxygenase. So this once heme oxygenase acts upon it, it is converted into bilirubin. And on the right side, you can see that at this point, carbon monoxide is released. So that is the physiology where we use EtCO2 to find out hemolysis. So now the biliverdin is acted upon by biliverdin reductase, and it becomes bilirubin. Unconjugated bilirubin will enter the liver and is acted upon by UDP glucuronide transferase UGT1A1 and gets conjugated. So if there is immaturity of the liver, if there is immaturity of this enzyme, the deficiency of this enzyme, then the result is that there will be high levels of unconjugated bilirubin. Now we should also remember that this conjugated bilirubin enters the intestine and is acted upon by intestinal flora, and thereby major chunk will be converted to the stercobilin and urobilinogen and will be released through feces and urine. And if there is a problem, that is, if the intestinal flora is not acting, if the feeding is not proper, then there is increase in enterohepatic circulation, and that again will cause high levels of unconjugated bilirubin. So hemolysis, immaturity of the liver, absence of intestinal flora, and increased enterohepatic circulation are important factors that should be kept in mind. Now, what is pathological jaundice? It is any jaundice which is visible in first 24 hours of life, yellow staining with the palms and soles or deep yellow appearance, and bilirubin values more than 95th centile for the gestation weight or age in hours, and presence of any warning signs of encephalopathy, such as poor feeding and lethargy. That also has to be taken into account. Now, the main learning objectives of this session is in the 6 headings. That is, we should be able to prevent hyperbilirubinemia. We should be able to identify the risk factors for hyperbilirubinemia and neurotoxicity, monitor the baby, offer treatment, and there should be a proper post-discharge follow-up, and we should have our own hospital or our own area policies. Now, coming to the prevention, it is actually a continuum of care. So it starts from the antenatal period. If we have a mother, if the gynecologist sees a mother with RH negative blood group, they definitely will do an ICT. And if it is positive, a history of getting NDD has to be elicited. If there is no NDD received, then it is actually indicating of the isoimmunization that is occurring in the baby. So the neonatal team has to be alerted. Baby need to be closely followed up. And once born, cord blood has to be sent for blood grouping, and RH typing and TSB should be intimated. We should also know the hemoglobin level, whether the baby's direct Holmes test is becoming positive, or we should look for evidence of hemolysis through checking retic count and peripheral smear. So isoimmune hemolysis is something which should be we should be able to identify, and we should not wait on such a baby. Now, the next important point in prevention is breastfeeding. So you can see the busy slide here. That indicates that itself indicates that how much we have to concentrate on helping the mother to breastfeed the baby properly, so that the baby will not go in for jaundice. So this is also an important aspect that will help in reducing jaundice. The new guidelines states about the suboptimal feed intake. So that has to be prevented. As doctors, as pediatricians, as neonatologists, as staff nurses, and as lactation counselors, we all can do our level best in reducing the problems that the mothers face in feeding. So that itself can reduce the jaundice level. So those two are the factors that are important in prevention. Now, the next is about identifying the risk factors of hyperbilirubinemia and neurotoxicity. So again, we have seen the Rh negative group. Now, O group with baby having A and B group is also important. Then gestation, the baby less than 38 weeks, lactation not well established, pre-discharge bilirubin, which is very high, then cephalhematoma, subgaleal hematoma, presence of previous baby with phototherapy or jaundice, then Down syndrome, and IDM baby who is macrosomic and polycythemic are also risk factors for hyperbilirubinemia. So in the history, we should always look for feeding issues, then birth weight and current weight of the baby is important. Also, we should concentrate on the activity and the behavior of the baby during sleep or waking up, any abnormal cry or movements, because that is very, very important feature to diagnose the acute bilirubin encephalopathy. The other features that are present will be hypotonia or hypertonia, lethargy, poor suck, irritability, high-pitched cry, seizure, and opisthotonic posturing. So one important aspect that we are concentrating while we are treating a baby with jaundice is prevention of bilirubin-induced neuronal damage. This is actually a spectrum where the baby may have subtle neuro dysfunction or acute bilirubin encephalopathy or chronic bilirubin encephalopathy. Chronic bilirubin encephalopathy is otherwise known as kernicterus, where the baby's unbound bilirubin crosses the blood-brain barrier and gets deposited in the basal ganglia, resulting in choriothetoid CP and enamel hyperplasia, sensory neural hearing loss, and upward gaze palsy. So as pediatrician, as doctors, we are supposed to prevent a baby from going in for kernicterus because this is such a preventable condition. Now, what are the risk factors for neurotoxicity? Asphyxia, lethargy, temperature instability, acidosis as per 2004 guidelines. And now a new term that is significant clinical instability has also been introduced. That is, we have to look at the baby and decide whether the baby has significant clinical instability. So the clinical judgment of the baby is very important. So once we prevent the baby from getting bilirubinemia or identify the risk factors, monitoring comes into picture. So we have to check the total bilirubin from which we should not subtract direct bilirubin. It is total bilirubin that is taken into account. Then the blood group, then if you suspect hemolysis, blood count, retic count, peripheral smear, DCT are all important, and in areas of high prevalence, G6PD deficiency has to be checked. Now, new AP guidelines talks about the importance of visual assessment. So here comes the importance of Kramer's criteria, where up to the face, the value is 4 to 8. In the upper trunk till umbilicus, it is up to 12. Lower trunk, that is up to thighs, the value is 8 to 16. And in the arms and lower legs, it is 11 to 18. Palms and soles, it is more than 15. Some say it's more than 18. And when you are using the Kramer's criteria, it's not just looking at the baby, but you have to apply your finger on the skin and blanch the skin. Usually it will be pinkish white, but if it's jaundice, it will appear yellowish. Now, the objective measurement is either using serum bilirubin or transcutaneous bilirubinometer. So that transcutaneous value is only used for screening. It should not be used for the definitive test for, it should not be used as a definitive test for guiding. it's actually the serum bilirubin that will be used as a definitive test for guiding to phototherapy or exchange transfusion. So when you use transcutaneous bilirubinometer, it is applied over the head, forehead, or cheeks or chest, and vertically it has to be applied, and the interface has to be in contact with the skin properly. Otherwise, will not get proper value. And TSB should be done if the transcutaneous value is within 3 milligram per deciliter of phototherapy threshold or more than 15 milligram per deciliter. That is, if transcutaneous bilirubinometer shows a value of more than 15, we have to definitely do a TSB. And if the baby's age is before less than 24 hours, TSB has to be done, or within for 24 hours of stopping phototherapy, we want to repeat a value, then it has to be TSB. You cannot use the transcutaneous meter because it may get affected by the pigmentation of the baby. And it is actually not the single value, but a trend of value that is important. Rise of bilirubin more than 0.3 milligram per deciliter per hour in the first 24 hours or more than 0.2 milligram per deciliter per hour thereafter is important. Now, one word about bilirubin albumin ratio. This becomes important at the exchange level threshold. That is, we should check the albumin value of the baby if we think that the baby is going in for exchange transfusion. In detail, we can see about this in the workstations that will come on Sunday. Now, after monitoring comes the treatment. So as a person, as a postgraduate or as a doctor who has been working from 2000s, I cannot forget Bhutani chart. Hence, I'm putting this chart here, but due to lack of time, I'm not talking about it. These are the AAP recommended charts now. Here we can see the y-axis has the total bilirubin and the x-axis has the hours as well as the days. So here you have the 35-week, 36-week, 37-week, 38-week, 39 and 40 weeks. So different lines are available, and actually the threshold has been raised. This is actually a chart for no neurotoxicity risk factors. And this is a chart for one or more hyperbilirubinemia risk factor. Here actually only 38 week is available. 39 and 40 has been displaced, which means that above 38 weeks, they have grouped into one. That is, if the bilirubin risk factor is there, the neurotoxicity risk factor is there, it is all grouped under 38 week itself. Now, let us come to one case. 36 week, 2.8 kg baby with OA setting, but feeding is okay and no other problems are there. The 48-hour value for this baby came as 16.4. So 48-hour value has come as 16.4 for a 36-weeker. So 36-weeker, the line is coming here, and the value is 16.4, which is somewhere here. So definitely the baby is in photozone. So we gave phototherapy for 24 hours, and after 24 hours, the value was checked. It was 13.4. So at 72 hours, the value is 13.34. It was stopped because the value has come down below photozone. After 5 days, this baby was called up again for follow-up because it is a 36-weeker and OA setting. And the value was after 5 days, that is baby's 8th day, the value became 19.75, which is actually close to photozone again. So this baby was again continued for phototherapy and discharged after 2 days. So phototherapy is a non-invasive, cost-effective, safe, easy technique to use. You should cover the diaper area as well as the eyes, and the baby can be kept under phototherapy. The range is usually 470 to 475 nanometers, which is actually what we call as the blue light. This area is what is known as the blue light, and the intensity recommended is 30 microwatts per centimeter square per nanometer, and the baby has to be as close to the light source as possible nowadays. There is no significance in keeping the baby at 45 centimeter as we used to say earlier, because the recent phototherapy lights are LED lights or CFL lights, so it doesn't cause any hypothermia. Always ensure that the baby has optimal breastfeeding and good stool output. Now, the new guideline actually recommends when we should discontinue phototherapy. That is, the value should be below the photozone at that time and below the photozone on the day of starting, that is 2 milligram below the photozone. And also we should look for rebound hyperbilirubinemia in most of the babies, especially the sepsis baby, preterm babies, or babies with any isoimmunization. Now, major addition to this guideline is the word escalation of care. This is actually something which I had way before heard from PMC sir. Escalation of care when the baby is going in for very high value. That is actually in maybe 2004, 2005 period. This was what sir used to tell always. That is, whenever the value is going very high, as close to the exchange threshold, that is considered as a medical emergency, and it includes admission to NICU, and the area should have exchange transfusion facility. Intensive phototherapy should be given where we do not take the baby out of the phototherapy. Intravenous hydration is must, and also oral hydration, and proper blood test should be done, and we should arrange blood transfusion. Then 2 hourly, 4 hourly interval, we should check the values, and if the values are coming down, we can reduce the intensive phototherapy or intravenous hydration. Whereas if the values are still going up, we'll go for exchange. Now, one word about intravenous immunoglobulin. It is a drug that has been recommended earlier and even now in the guideline, 0.5 to 1 gram per kg given over 2 hours. It can be repeated in 12 hours in patients with isoimmune hemolytic disease. But if we give intravenous immunoglobulin early on, it is actually not going to help the baby, because a lot of hemolysis is being taking place, and this immunoglobulin will not be able to block the hemolysis that is happening. So there has to be a time when you give, if it is still increasing, a repeat immunoglobulin also should be given. Now, regarding exchange transfusion, it should be done on babies who are not responding to intensive phototherapy. Any signs of early encephalopathy or any signs of late encephalopathy warrants exchange transfusion. We learned more about exchange transfusion in our workstations. Now, this is the chart that is followed for exchange transfusion of babies with no neurotoxicity. You can see that the value is a little high for a 38-weeker. At 48 hours, the value is 24. One more case, 37-week, 3 kg baby born to a mother with no blood group incompatibility, but the baby had low platelet and prolonged PTINR at the outset itself. That is, at immediately itself, we noticed that the baby had bleeding tendency. And this baby had, at 12 hours, the value was 12. By 18 hours, it was rising to 17 in spite of starting phototherapy and intense phototherapy. And by 24 hours, it went up to 22. Exchange transfusion was done on this baby on day 2. This baby finally turned out into familial HLH. So this is for neurotoxicity risk factor. Previously, I showed the chart where for a 38-weeker, the value of exchange was 24. If there is a risk factor, the value is reduced to 20. So we have seen the treatment. Now, post-discharge follow-up, our specific chart which we had been using is no longer recommended. Now, we say that in follow-up, we should look for lactation problems, exclude early signs of encephalopathy. Any baby with risk factor should be followed up within 24 hours of discharge, or a baby for whom we think there are risk factors, actually close follow-up within 24 hours or within 48 hours is required. Now, in the post-discharge follow-up, actually because the hour-specific nomogram is no longer used, it is actually the difference between the TSB value of the baby at discharge and the phototherapy threshold. Suppose at 48 hours, if the baby's value is 12, and the baby is a 38-weeker, the phototherapy threshold is somewhere around 17, and the difference between 12 and 17 is 5. So there is 5-point difference. So this baby can wait for maybe 3 or 4 days till we call back the baby at for follow-up. Whereas if it is 1, then within 24 hours, we have to follow up. So even after follow does not just mean immediate follow-up. We have to do the developmental screening, look at the language milestones, always evaluate the hearing, especially the BERA. Now, regarding the hospital policies, we have seen that the AAP has raised the threshold of exchange transfusion as well as the phototherapy, recognizing the fact that bilirubin neurotoxicity occurs well beyond the threshold of 2004 guidelines. But strict monitoring and follow-up is required. But we know that in our crowded facility, in our place where the patients may not be listening exactly to what we are telling them, a lower threshold for initiation of treatment is recommended. This AAP guideline is not completely recommended in LMIC countries. So we can formulate our own policies based on this AAP guidelines. Now, without telling a word about prolonged jaundice, I think I should not stop this topic. So prolonged jaundice means a jaundice that is extending beyond 2 weeks for a baby who is young, and jaundice that is extending well beyond 3 weeks for a baby who is preterm. So definitely we should ask for whether the baby has pale stool or high colored urine. So this card is actually helpful. The lower color of the stool is acceptable. The lower 3 colors, the yellow and the green color, is acceptable, but the pale clayey color is not acceptable. Check for adequacy of weight gain. Do the direct bilirubin in this case. Investigation includes other things like the LFT, the gamma glutamyl transferase, thyroid function test. We should always look for urine culture because that is the commonest cause that is going to cause prolonged jaundice. We should look for inborn error of metabolism, torch screening, intrauterine infections are important. Ultrasound abdomen to rule out treatable causes like choledochal cyst and biliary atresia is important. Also, other evaluations like viral hepatitis screen, later on liver biopsy if the baby is not improving. And a very important pertinent question which we cannot escape at all when we are talking about or dealing with hyperbilirubinemia is whether my baby will improve with sunlight exposure. But scientifically speaking, we know that for 470 to 475 nanometer or 460 to 490 is something which comes from sunlight. So we can expose the baby, but how long can we expose without causing problem to the baby, without causing sunburn or without causing hypothermia to the baby? And we are giving phototherapy for 24 hours or 48 hours. Can we give that much sunlight to the baby? So these things, when we address to the parents, they will understand that sunlight exposure is not the thing that is going to help a baby who definitely needs phototherapy. But breastfeeding is something which we should encourage and we should counsel frequently so that the baby will have adequate stooling, adequate weight gain, and that can prevent or reduce the incidence of hyperbilirubinemia. With that note, I would end the session. Thank you.
Thank you so much, ma'am.
I think I exceeded a little time. I'm sorry, Fairy.
Screen sharing. Sorry for that. There was a technical. Okay. Yeah. Next, we'll move on to the next session of Ferry. Delivery room management of newborns, term and preterm, do's and don'ts. Over to Dr. Ferry. Dr. Ferry, it is visible.
No, Ferry is unmute.
Ferry ഒന്ന് unmute ചെയ്തിട്ട് ഒന്ന് പറയാമോ? Ferry audio കേൾക്കുന്നില്ല. Not audible.
Unmute അല്ല.
Ferry ഒരു മിനിറ്റ്. Ferry can unmute herself. Ferry ഒന്ന് unmute ചെയ്യാമോ? Ferry Ferry audio കേൾക്കുന്നില്ല. അൺമ്യൂട്ട് ചെയ്തിട്ടൊന്ന് ചെയ്യാമോ? Ferry കേൾക്കുന്നില്ല.
Benno, question answer discuss ചെയ്യാനാണ്. Chat.
Sir, I think PMC sir, there is some technical issue. I've asked Ferry to send me the presentation, and I think she'll enter through via phone. അങ്ങനെ വേണമെങ്കിൽ നോക്കാം sir. I think we'll take the questions. Meanwhile, Ferry on the screen share. Screen sharing Ferry on the Ferry on the ഇപ്പോൾ ഒന്ന് audio ഒന്ന് പറയാമോ? Okay. I think I'll take one question from Bala sir. Giving probiotics for neonatal jaundice followed in any of the following hospitals? I think the answer has already been given by Dr. Gayatri. Yes. Hazeena madam, any take on that?
Particularly for jaundice, I have not given for term babies especially, but preterm babies already they are on probiotics. For term babies, neonatal jaundice, I haven't given.
Okay. Okay. sunlight can be discouraged.
Let me continue that question
Sure.
to Gayatri. If probiotics are given, which probiotics?
Madam, I think lactobacillus. Okay, Dr. Gayatri. I think the question is to Dr. Gayatri. Asine, madam?
Yes, I was because she was telling yes, I was asking her. You are using, you can also answer, Benno.
Ma'am, I'm not routinely giving any probiotics. Only for that colicky pain, that lactobacillus root, that is what we give normally. For phototherapy,
there is no definite consensus.
Yes. So
Jayakumar was using it quite often in Amrita, but now nothing has been substantial.
Yes. There was one question, 35-weeker postnatal day 10, total bilirubin 21, decreased activity, how to approach? 35-weeker, postnatal day 10 means this is a preterm baby. So until 14 days, physiological jaundice can be there in a 35-weeker. But the value is now 21. Decreased activity, we should look whether the feeding is okay, whether the baby is having any sepsis, those kind of things also should be looked into. And here, what matters is isoimmune hemolysis also should be looked into, whether the group RH incompatibility, OA incompatibility is there, whether the baby's weight is adequate for a 35-week SGA or AGA baby, whether the baby have polycythemia. So those kind of things also matters. We should look into the whole picture of the baby and then approach. If really decreased activity and tone is abnormal and baby is not feeding well, we should take it as acute bilirubin encephalopathy, and we should start intense phototherapy for the baby. Plan for exchange transfusion if it is required as per the guideline. If it is, you should look into the chart, AAP guideline, and follow the baby every 2 hourly, so that you see whether 21 is becoming suddenly 24 or 26, and then we cannot wait on the baby, we'll go in for exchange transfusion. But if we start phototherapy and the value is coming down in 4 hours, then we can very well wait on the baby and the baby's activity is improving. I think I answered the question. PMC sir, anything to add on?
No, agree. Because the decreased activity is one worrying thing here.
Yes.
Whether it is sepsis or whether it is bilirubin. Anyway, what is said is correct. This is how we approach it.
Sunlight we can discourage. Yes, sir. We should discourage, sir. In the sense, we cannot advise sunlight as a therapy for babies. Scientifically, the wavelength of sunlight is something which reduces the bilirubin value. That is scientifically correct. But then, how long can be given? How should it be given? Whether it is safe to the baby? Those kind of things are always in question, sir. So we cannot definitely allow a baby, because mostly all of us, or at least people popularly say sunlight exposure is okay. So even if the baby has a value of 18 or 19 and we advise phototherapy, most of the parents will tell that others are telling sunlight exposure is fine. So it is very difficult in counseling such a scenario. That is why the physiology and explaining what is happening inside the body of the baby is important. The parent counseling is very, very important in managing a baby with hyperbilirubinemia.
Sorry, Hazeena madam. Next question. Sunlight can be discouraged by Bala sir.
Yes, I answered that, Benno.
Sorry. Okay. Any other questions? Okay. I have asked Fairy to get in through mobile by using mobile. So I'll do screen sharing. Is it visible?
Didn't open, Benno.
Open illa?
Illa.
No.
Okay. Sorry. Once again. Madam, is it visible now?
Nice.
Yeah.
Okay. Now, in case Fairy ki kera patiliki, shall I do the presentation?
Yes. But just see whether she can.
Yeah, I'll just. Yeah.
Okay, am I audible?
Yes, Fairy.
Okay.
Fairy, രണ്ടെണ്ണം open ചെയ്തിരിക്കുന്ന ഒന്ന് മാറ്റണേ. The previous one ഒന്ന് close ചെയ്യാം.
Okay.
രണ്ട് login ചെയ്തിരിക്കുന്നു.
Laptop close ചെയ്യട്ടെ.
Laptop close ചെയ്യാം. Echo ആവും.
Okay.
Yeah.
Still like. ഒരു second.
Laptop. Okay.
Okay.
Right. Yeah.
Am I audible?
Yes.
Okay. So this is the last session for the online series. My topic is delivery room management of newborns, term and preterm. It is just a summary of the NRP. So coming to the first slide, the number of personnel required at the delivery room. First of all, if it is a delivery having no risk factors, there should be only one person, but that person should be skilled in at least the initial steps. That is, the stimulation should be done and also the bagging should be done. Beyond bagging, even if the person is not well versed, it is okay. But if there are no risk factors, the one person should be skilled at least till the bagging. But if there are risk factors, at least two persons who should be able to initiate the resuscitation and must be able to do advanced resuscitation. That is up to including intubation, chest compressions, and the medication should be available. And if at all any baby can get sick very fast in the delivery room, the baby may cry. Again, the baby can go into apnea. In that case, always keep the numbers of the referral unit and also the transport system should be ready. And the new consensus is that we have to discuss the umbilical cord management even before the delivery happens with the obstetrician, and also if it is a CS, it should be discussed with the anesthetist. Next slide. So if it is a well baby, the first thing is we have to note the time of birth. So the time of birth is when the last fetal part comes from the mother's body. Okay. And as you all know, the new consensus is as soon as the baby is born, the baby has to be kept prone on the mother's abdomen for skin-to-skin contact, and it should be uninterrupted for at least 1 hour. And this is to prevent the evaporative heat losses. Next is early breastfeeding. That is also to prevent hypoglycemia and also to provide warmth. And the current consensus is delayed cord clamping. According to NSSK, it is 1 to 3 minutes. And according to the AAP guidelines, it is 30 to 60 seconds. So what is delayed cord clamping? Why is it recommended? So at the time of birth, a large volume of blood remains inside the placenta. So what happens is that if the mother's blood is continuing to flow into the placenta, and if the cord is not cut, so what happens is that the placental gas exchange will take place for a longer time. And so the baby will get some amount of additional oxygenated blood. So this additional oxygenated blood plays an important role in the transition from the fetal circulation to the neonatal circulation. And it has been found that in the term babies and in late preterms, that is beyond 34 weeks, this delayed cord clamping, that is after 1 minute, it has got advantages of better neurodevelopmental outcome and also improved early hematological parameters. At the same time, in preterm babies, it has been shown that delayed cord clamping has got improved survival rates, and also there is decrease in the amount of blood transfusions which happen during the hospitalization, and also there is decrease in the need for medications to support the blood pressure of the baby after birth. Although there is a small risk of the baby getting jaundice requiring phototherapy, delayed cord clamping is what we recommend, especially if the baby is a vigorous baby. And then we have to go for the routine care. So there are certain conditions where you have to go for the early cord clamping. One is, as I said, if it is a non-vigorous baby, then the second condition is when the placental circulation is not intact. For example, when there is an abruption, or if there is a bleeding placenta previa, bleeding vasa previa, or cord avulsion, etc. The third situation is a multiple pregnancy. That is because all the studies for delayed cord clamping has not included multiple gestation. So that is the only reason for multiple gestation, because the safety data is not available. We better go for an early cord clamping. And also there are certain situations where we have to discuss with the obstetrician whether to go for an early or a delayed cord clamping, where the safety data has to be again reinsured. These conditions are when the placental circulation is not intact, or when there is an abnormal umbilical artery Doppler, or when there is a fetal IUGR. Next slide. So coming to the preterm delivery, already PMC sir has mentioned about it. So if it is below 32 weeks, always what is recommended in the NRP textbook is that the delivery room temperature should be 23 to 25 degrees Celsius. For our term babies, it is 26 to 28. But if it is less than 32 weeks, what is mentioned is 23 to 25 degrees Celsius. And also, for below 32 weeks, the baby has to be wrapped in a plastic or a polyethylene bag or a wrap, and no need to dry the baby. And also there are some thermal mattresses available in Western countries, and also the embrace what we use in some private hospitals. So that is also recommended if it is less than 32 weeks. And the picture shows a T-piece or a neopuff or a delivery room CPAP. It has to be carried for all the preterm deliveries below 32 weeks. And no routine drying is recommended, because we have to just keep the baby inside the plastic bag or a polyethylene bag, because drying again, it will expose the baby to some amount of cold temperature. So better to keep the baby inside the plastic bag or the wrap. Next slide. Again, coming to the medications, as you know, even after doing chest compressions, and again, if the heart rate is below 60, we go for the medications. So the only medications recommended are epinephrine, normal saline, and PRBC, that is O negative. So previously, we used to recommend ringalactate also, but ringalactate is not there in the list. The reason is that ringalactate contains sodium, potassium, calcium, and lactate. So because it contains calcium, it cannot be infused into the same IV line as PRBC. So it is not recommended now. Again, adrenaline with the proper dilution, that is the stock solution, has to be made before the delivery, and it has to be prepared and labeled properly, and it has to be flushed and kept ready. So how to make the stock solution and how to dilute it will be discussed on Sunday during the workstation. Next slide. Again, for a non-vigorous baby, that is if the baby is not showing any breathing, or even after doing the normal routine care like wiping the secretions, etc., we have to clamp and cut the cord immediately and shift the baby to the radiant warmer. And we have to go for the observational care, which is with the mother. So for observational care is done for those babies who require initial steps, that is up to the stimulation part, and also if the positive pressure ventilation, that is the bagging, is done for less than 1 minute. Next slide. Again, meconium stained amniotic fluid. Previously, for MSA of non-vigorous babies, there was a practice of doing intubation and tracheal suctioning and also stomach wash, which is not recommended now. The reason is that studies have shown that this intratracheal suctioning and stomach wash, it doesn't decrease the incidence of meconium aspiration syndrome. And basically, it is the fetal acidemia or the fetal hypoxia which is causing the fetus to it increases the intestinal peristalsis in the fetus. So this causes the meconium to pass, and also it causes fetal gasping. So it is the fetal gasping which pulls the meconium stained amniotic fluid deep into the lungs. And that is the reason why the baby gets the meconium aspiration syndrome and again worsening the hypoxia. So our job is to prevent the fetal gasping or correct the ventilation so that the meconium doesn't reach the lungs. So as previously done, practices like stomach wash or intraamniotic infusion with normal saline. Previously, it was thought to dilute the meconium and thereby reduce the fetal acidemia. But now it has been shown that it has no role in reducing the incidence of meconium aspiration. It not be done. So even if it is a non-vigorous baby and with meconium stained amniotic fluid, just proceed just like another baby who is not vigorous, and no need to do stomach wash and routine intubation and intratracheal suctioning. Next slide. Okay, so coming to the warmth, the baby should be totally unexposed, should be uncovered so that maximum amount of heat reaches the baby. And we should start with the manual mode. It should be switched on 20 minutes before the delivery with maximum heater output. And if you feel that the baby needs prolonged ventilation or prolonged resuscitation, you can change the mode to servo control and make sure that the temperature is 36.5 to 37.5. Next slide. Suctioning. No routine suctioning is recommended. Previously, it was done for every resuscitation, but now it has been mentioned that no routine suctioning is done. Only if there are visible secretions, it should be done. And always the mouth first and then the nose. The reason is that if at all you suction the nose first, then if the baby gasps, whatever is there in the mouth will reach the lungs and the baby will get aspiration pneumonia. So always suction the mouth first and then the nose. And it should neither be too deep and not too prolonged. Mouth, the recommended length is 5 centimeters from the lip. Nose, it is 1 to 2 centimeters. And the duration also should not be prolonged. It should be 3 to 5 seconds. And too prolonged and too deep suctioning, it can cause vagal stimulation and cause apnea and bradycardia. So it should not be done. And only suction while we are withdrawing the tube. When you're inserting it, it should be closed. And the recommended pressure is 80 to 100 millimeters of mercury. Next slide. Okay, so this is also an important slide. So whenever you start bagging the baby, when you ask the staff to give you the ambu bag, immediately they will connect the oxygen tubing to the ambu bag. Actually, it is not recommended now because, as you can see, in term babies, that is more than or equal to 35 weeks, 21% oxygen is the starting oxygen concentration. So you don't have to connect the oxygen tubing or the reservoir. And in a preterm baby, less than 35 weeks, the recommended FiO2 is 21 to 30%. So ideally, you have to use an air oxygen blender, which is shown in the picture, but it is a costly thing. It's better. Okay, again, as you all know, these are the ventilation correction steps, MR SOPA. So P stands for pressure increase, M is mask repositioning, then R stands for repositioning the airway, S is suction, O is opening the mouth, P is pressure increase, A is alternate airway. So for a term baby, the maximum pressure allowed is 40 centimeters of water. And for a preterm baby, it is 30 centimeters of water. In some ambu bags, the pressure manometer is available. Next slide. Okay, so always should be connected on the right hand to get the preductal value. And it should be done whenever you're starting a bagging, positive pressure ventilation, whenever you're doing a prolonged resuscitation. Also, when you feel that the baby has cyanosis, like we may feel that the baby is blue, so you should confirm it with the pulse oximeter. And also, whenever you're giving supplemental oxygen, and always titrate with the target oxygen saturation table. This table should be there in all the labor rooms. It is according to this table that you have to guide the oxygen therapy. For example, at 1 minute of life, when you attach the pulse oximeter and you get a saturation of 6 to 2, don't immediately give oxygen because it's a normal value. Next slide. Okay, so these are two changes in the stimulation and chest compression part. So the only recommended method for stimulation is rubbing the back 1 to 2 times only. No flicking the sole, no shaking also. And also chest compression, only the 2 thumbs and fingers encircling method should be used. And you should always stand at the head end of the bed. And the 2-finger technique is also no longer recommended. Next slide. Coming to the ET tube, all the fixation materials should be cut and kept ready, especially the dynaplast. And the labor room should also have the depth chart, that is the insertion of the ET tube, the depth of insertion, or the rough calculation is nasotragal length plus 1. And the time for one attempt is 30 seconds. So if you are not able to intubate in 30 seconds, you should stop and start giving the positive pressure ventilation. And then when the baby saturation comes up, again, you have to attempt. And maximum, the better to attempt only twice. After the second attempt, it is better to give it to another person. And whenever you have a bradycardia or a fall in oxygen, stop and give positive pressure ventilation. Because if you continue to attempt doing the intubation, the baby might go. Next slide. So this is a picture. The first picture is showing the measurement of the nasotragal length from the bridge of nose to the tragus of the ear. The second picture is showing administration of epinephrine. You can see the 3-way stopcock. And from one side, he's trying to push the adrenaline and as quickly as possible. And on the other side, there is the 3 ml normal saline flush, which is given immediately after the adrenaline. It is given through the 3-way stopcock, and you can see it is attached to the umbilical line. This will be explained during the workstation on Sunday. Next slide. Okay, coming to the orogastric tube. So whenever you're doing a PPV, either with a bag whenever you're using a mask, that is either with a ambu bag or with a neopuff, we can see that a lot of air enters into the esophagus and the stomach. So this can interfere with the ventilation. So whenever you feel that the baby needs prolonged ambu bag or prolonged neopuff ventilation, always make sure that an orogastric tube is inserted. And the recommended size is 8 size OGT, and it has to be inserted. And the measurement is taken initially by measuring the distance from the bridge of nose to the ear lobule, from the ear lobule to a point midway between the siphisternum and the umbilicus. So note the measurement in centimeters, and then you have to insert the OGT, and then you have to aspirate the gastric contents and keep the cap open so that it acts as a vent for the stomach. So this will deflate the stomach and make the ventilation proper. Next slide. Okay, so whenever there is a persistent cyanosis, that is, even if the baby is breathing spontaneously, the heart rate is normal, but if the oxygen saturation is not meeting up the target levels, we have to give the free flow oxygen. But make sure that the free flow oxygen is given only if the baby is breathing spontaneously. Okay, and when the saturation is noted, it has to be below the target range. So how to give the free flow oxygen? We have to hold the oxygen tubing close to the baby's mouth and the nose. You can also give it via a mask, which is kept close to the baby's mouth and the nose. Do not give with the mask of an ambu bag, but you can give via a reservoir. The reason is that if you just hold the mask of the ambu bag and you feel that we are giving free flow oxygen, but the compressed air will enter into the baby only if you squeeze the bag. So without squeezing the bag, if you just keep the mask of the ambu bag in order to give free flow oxygen, the baby will not be getting any oxygen. So don't try to give with the mask of the ambu bag. And you can give with a reservoir if it has got an open end. And the starting for free flow oxygen, the starting flow is 10 liters per minute, and 30% FiO2 is what is recommended to start, and then we have to adjust according to the target oxygen level. So this 30% we will know only if you have a blender in the labor room. Next slide. So suppose you don't have a blender in the labor room. So how do you get the 30% oxygen? So what you have to do is we have to start with 100% oxygen. That is, every labor room will have a flow meter which is connected to the oxygen. So just start the 100, whatever you're getting from the oxygen tubing is 100% oxygen. And this 100% oxygen, it gets mixed with the air. Air has got 21% oxygen. So we have to adjust the distance of the tubing from the baby's face for titration. That is, if you're holding the baby's tube, the oxygen tube close to the baby's mouth and nose, it has got a higher oxygen concentration. And if you're holding it a little away from the baby, then it has got a lower oxygen concentration. So it depends on the amount of air it is getting mixed, so that the oxygen concentration can be titrated. And the titration is according to the pulse oximeter and the target levels, target level oxygen saturation. Next slide. So when to stop resuscitation? After extensive resuscitation, that is, you have done the bagging, intubation, chest compression, adrenaline, and even after 20 minutes, if there are no signs of life or if the heart rate is absent, then you can stop resuscitation. Next slide. And always remember, documentation is very important. Whatever you have done, you have to document it in the file. And also you have to communicate with the family and also do a debriefing with the team so that the next resuscitation can be improved. Next slide. Okay. So to summarize, these are the do's and don'ts of the delivery room. If there are risk factors, 2 persons should be present. Always make arrangements for referral and transport if at all it is required. And discuss the umbilical cord management with the obstetrician and also with the anesthetist if it is a C-section. For a vigorous baby, always practice skin-to-skin contact uninterrupted for 1 hour. Early direct breastfeeding to prevent hypoglycemia. Delayed cord clamping, that is 30 to 60 seconds. And routine care, that is with the mother. The mother has to monitor the breathing and the color. And if it is a non-vigorous baby, you have to go for the early cord clamping and keep the baby immediately under the radiant warmer. Go for the initial steps, which include stimulation and bagging if needed. And observational care is for those babies who require stimulation or bagging below 1 minute. For meconium-stained amniotic fluid, no routine tracheal suctioning is needed. No stomach wash is needed routinely because both of them will not reduce the incidence of MAS. Preterms below 32 weeks, always start resuscitation by receiving them in a plastic bag, and you can keep them on a thermal mattress if it is available. TP's resuscitator should always be carried, and the delivery room temperature is 23 to 25 degrees Celsius. Medications, the only 3 medications recommended are epinephrine, normal saline, and PRBC, no role for ringer lactate. Epinephrine, the stock solution, and the 3-way should be ready. The flush should also be ready. Everything should be labeled and kept ahead of the delivery. Then the warmer, you start with the manual mode. If it is prolonged, you can switch on to the servo mode, and the baby should be uncovered. And the delivery room, the recommended baby's temperature is 36.5 to 37.5 degrees Celsius. Suctioning, mouth first, then the nose. Mouth, the distance is 5 centimeter maximum. Nose is 1 to 2 centimeters. Duration 3 to 5 seconds. It should be done only during withdrawing, and the pressure is 80 to 100 millimeters of mercury. Next slide. For bagging, the initial oxygen concentration is 21% if more than 35 weeks and 21 to 30% less than 35 weeks. So do not connect an oxygen tubing or a reservoir for starting a bagging for a term baby. And always use a neopuff when you're resuscitating a preterm baby so that the correct oxygen saturation can be maintained. Ventilation correction, MR SOPA, the maximum pressure permissible for a term baby is 40 and preterm baby it is 30 centimeters of water. The saturation probe should always be connected to the right hand and use the target oxygen saturation table, which should always be pasted in the labor room. Stimulation only by rubbing the back, and that too 1 or 2 times only. No flicking the sole, no shaking. Chest compression should always be from the head end of the baby. And the only method recommended is thumbs and fingers encircling. No 2-finger technique. Then intubation, fixation materials, and the depth chart should be ready. The maximum time you can take for 1 attempt is 30 seconds. And after that, you have to bag the baby. And if there is any bradycardia or desaturation, again, continue to give PPV. Otherwise, we may lose the baby while attempting to intubate the baby. When there is a prolonged positive pressure ventilation, always make sure that a orogastric tube is inserted. Free flow oxygen should be given only to a baby with spontaneous breathing, and start with 10 liter per minute of oxygen. And if you have a blender, 30% of oxygen, and titrate based on the chart. Documentation is important, communication with the family, and debrief with the team. Next slide.
Maybe I think 20 minutes is over now. So 1 second.
Last slide.
Last slide.
Okay, so these are the don'ts. There is no role for ringer lactate, DNS, naloxone. For meconium-stained amniotic fluid, no routine tracheal suctioning, no stomach wash. Then no routine suctioning, only if there are visible secretions. It shouldn't be deep, it shouldn't be prolonged. For a term ambu bag initiation, no oxygen tubing, no reservoir. Stimulation, no flicking the sole, no shaking. chest compressions, no 2-finger technique, no standing on the side. Free flow oxygen don't give if the baby is not breathing. It shouldn't be given with the mask of an ambu, and no resuscitation beyond 20 minutes if no signs of life. Thank you.
Excellent presentation, Ferry. As always, very crisp and very clear. Any doubts from the audience can be cleared. Bala sir, any doubts? Jayanti ma'am? Bala sir, please.
No, clear. It's all clear. Very clear presentations. Thank you all the faculties. We'll meet again on Sunday.
Thank you, sir.
I have to leave a meeting. Is there at 9:30?
Sure, sir, sure.
Thank you all. Bye.
Thank you, sir. Thank you. Bye, sir. Jayanti madam, any suggestions? PMC sir, any PMC sir, any suggestions or
no? I think
anything to be added, sir?
We can wind up, I think, because anyway, most of the presentations are clear by themselves.
Okay.
And anyway, we are having a physical section also.
Yes, sir. So, anything from the audience? I think if nothing is there, I think we'll wind up the session. So, my sincere thanks to IAP State President Riyaz sir for giving us this opportunity, as we told in the first session itself, and hope that all the 3 sessions were actually very useful for all the delegates. And next, I would like to thank our IAP Trivandrum President, Kalpana Madam, for this constant support and guidance. It's very special or sincere thanks to our beloved PMC sir. In spite of sir's health issues, sir was able to guide us and help us through all the presentations, and sir also gave us the advice to make the presentations crisp and very short. So thank you very much, sir. And even my guru Naveen sir, who had given us valuable suggestions and made it very crisp and clear for all the audience. May I invite Kalpana Madam to speak a few words? Kalpana Madam?
Did you answer the questions and ask?
All the questions it was all answered, Madam.
So we had 4 sessions in this, very useful sessions, and it was well presented and very clear also. And if there are any comments or questions for others, you can ask. And I wish the last day's program all the best.
Thank you, Madam. Thank you. Last but definitely not the least, I thank all the delegates for the patient listening and the valuable inputs. Thank you. Thank you all.
Bye. Thank you, Benno.
Thank you, sir. Thank you, Madam.
Thank you, PMC sir, for being with us for all these 3 days.
Thank you.
Thank you, sir. Thank you, Madam.
Sir, and the enthusiasm, Madam, that's the thing which kept us going. Thank you, sir.